Wow, some fantastic insights there on nutrition programs, certainly SNAP and outreach programs. Next on the agenda, welcoming to the program Roseanne DiMaria-Ghalili from Drexel University.
Well, I'm so happy that there are still people here this evening. And I'd like to thank the organizing committee for inviting me to participate in this. So my research has been focused on malnutrition in older adults, particularly in older adults who are undergoing surgery. So I've been very much interested in looking at what happens, what are the risk factors before folks come into the hospital, what happens while they're in the hospital, and then most importantly, what happens when we send them home to recover. So I was very happy to talk a little bit today about nutrition during care transitions, but I've been tasked with talking about exemplars from some of the CMS Innovation Grants programs and looking at what's been done at the national level for nutrition during care transitions. So I think at this point of the day, we should say, let's begin with the end in mind. And this is an example of what we don't want as a good care nutrition care transition. And it's been in the news, and if you Google it, you could get the whole news story. But it's a story about an elderly man in Fayetteville, North Carolina, who's 81, that called 911 after being discharged from the hospital because he couldn't get out of his chair because he had no food. And he went home to a house that had nothing after being in the hospital for a couple of weeks. So, and it was a good, it was a story where, you know, the 911 workers brought him food, and it was a really, but this gets to the point of what we're getting at here for care transitions. And recently, in September, was Malnutrition Awareness Week, and the American Society for Parenteral and Enteral Nutrition is very much spearheading some of the malnutrition initiatives at the national level. And they just published a paper that was in the Joint Commission Journal of Quality Patient Safety. And you know, the Joint Commission sets standards of care for our hospitals. And Aspen states that it's the position of Aspen that addressing disease-related malnutrition in hospitalized patients should be a national goal in the United States and thereby help to improve patient outcomes by reducing mortality, morbidity, and costs. Okay, so let's keep this in mind then about what are some of the facts related to hospital malnutrition, and that we could see how we move into then this issue of care transitions. We know that from some data looking at some large data sets from Healthcare Utilization Project, that patients that had a medical diagnosis, an ICD-9 diagnosis for malnutrition in their medical records while in the hospital were 65 years, tended to be older, have higher rates of infection, longer lengths of stay, higher costs, and higher rates of death. We did a secondary analysis on that data set to just compare the young and the old, and we found that the older adults with a malnutrition diagnosis were more likely to be admitted to the hospital from a skilled care facility and more likely to be discharged back to a skilled care facility. Other researchers have found that weight loss, and this is in all patients with hospital malnutrition, that weight loss increased the risk of 30-day readmission in medical patients, and that failure to thrive and malnutrition was a frequent reason for readmission in surgical patients. And we can't forget Krumholtz, who talks about post-hospital syndrome, and that malnutrition very much contributes to this phenomenon. And recently, Aspen has published a lot of information on their nutrition care algorithm, but we need to remember that, if I could get this right, okay, so that when we talk about care transitions, when people come into the hospital, right now the Joint Commission requires that patients have a nutrition screen performed within 24 hours on admission to the hospital, and most often nurses are doing that screening. But however, people then go through the hospital stay and get ready to be discharged, but we don't require a nutrition screen again prior to discharge. And that's really important as we start talking about care transitions. Okay, So here's my transition logic. Older adults are at risk for malnutrition. Malnutrition impacts readmission. Transitional care can impact hospital readmission rates. So what evidence then is there at the national level to support nutrition during care transitions? Okay. So during the Affordable Care Act, CMS was issued funding to provide what they call innovation awards. And there were several innovation award programs that were developed. One was on transitional care. And I didn't want to really waste much time because when you go through the document on the first year report, when I scrolled through the document and searched, nutrition was found once. So I thought we maybe would take some time and look at some of the grant recipients of the Healthcare Innovation Awards. So again, there were 107 programs that were funded in the first round up to $1 billion throughout the United States. And what I went and did was really looked at, there were about 21 programs that targeted reducing hospital readmission rates. I hand-searched all of the abstracts from the first round and also searched in the PDF, and only one of those case studies focused on nutritional risk in older adults, and I'll talk a little bit about that. And then I searched the one-year evaluation reports that were published for the complex, high risk, and disease-specific, and I came up with a few interesting case studies that I'm going to share with you now. So the first case study that I want to highlight is called Bridging the Divide. And the focal population here is cardiovascular disease. And this is from the Christiana Health System in Delaware. So one of the interventions that they focused on here was a transitional care coordination, begins at inpatient admission through post-acute care. And then the longitudinal care management starts on day 61 in the outpatient setting with proactive monitoring, notification of health events. And what's really interesting about this model is that Delaware very early on was very much engaged in this health IT, so that it is a very connected state, okay? And what is interesting here is that there is an interprofessional care team. There's a doc, a physician, a hub manager, care managers, social workers, inpatient care managers, a health ambassador, that's a layperson, and a pharmacist. The only nutrition that's mentioned in this model is that the care management staff are trained on health topics relevant to their work. And in this example, it's cardiac nutrition. Okay? Some of the strengths of this model is that the enrollment into the program is based on predictive analysis, analytics, and that the program assigns patients to one of three risk groups, and the interventions that they get are based upon their risk group. And Christiana reports that this is a very sustainable program, and they're looking to adopt it post the end of their grant. The other program I want to talk about is from Vanderbilt, and it's called My Health Team, and they target patients with acute MI, pneumonia, CHF, chronic kidney disease, diabetes, hypertension, and COPD. And again, it's an intervention where there's an inpatient clinical care coordination using health IT and patient education, as well as an outpatient chronic care program. And again, the risk level determines the intensity of the services. And again, we can look at the team. It's interdisciplinary: nurses, social workers, outpatient care coordinators, docs, medical assistants, and pharmacists. The only mention of nutrition in this program is that the outpatient care coordination activities include chronic disease education for patients, such as nutrition and exercise, and that the transition care coordinators monitor dietary compliance. All right. Another program that's interesting is from Duke, or Duke is one of the primary settings here, is called the Southeastern Diabetes Initiative, and it's looking at targeting adult residents in the diabetes belt to improve care for diabetics. So what they're using are spatially enabled informatics systems, really looking more at the population level, and then focusing on patient care management and, again, risk algorithms to group patients into three intervention groups, each with different intensity of services. The team varies by site. There's 4 different sites here. Every site has a physician, but not every site will have a nurse practitioner, pharmacist, or a dietitian. And actually, this is the only model in which there is a dietitian, but it's not in every single site. Okay? The A model is the Advanced Illness Management Program by Sutter Health Corporation, and targets patients with high burden of disease. And these are people who are not hospice appropriate, but physicians think that they're, or deem them to die within the next 12 months. And they have a rapid, significant functional or nutritional decline associated with recurrent and unplanned hospital admissions. And again, the interventions delivered by nurses and social workers to really promote this continuity. The targeted population is nutritional decline, but they don't talk about how they measure this in the report. And finally, on the last really interesting model, again, is another program from Vanderbilt that looks at the collaboration between acute and post-acute care. And I found this fascinating. They have the IMPACT program, which looks at the improved post-acute care transition program for in-hospital services. So this is for patients that are coming from a skilled care facility. There's a transition advocate that works with the patient from hospital to discharge back to the skilled nursing facility. And they actually follow up with the skilled nursing facility 72 hours later to answer any questions that the staff may have. And then there's this INTERACT model, which takes this model into the skilled care facility, and they implement things called stop and watch to document changes in the patient conditions that are associated with early warning signs of readmission, and of course the structured communication. Nutrition is included in this in such that screening on the hospital side, screens are done for geriatric syndromes, and they state including malnutrition. And what's really interesting here is that Vanderbilt has really gotten on the transition management bandwagon, and they have really kept this transitions management office open to manage all transition-based projects throughout their medical system. Part of the nurses actually reported that there were inconsistencies in the medical record, and that if they relied solely on the medical record to screen patients for their IMPACT program, it would cut down 50% on their labor intensity, but it would impact or cut down 100% on their accuracy, because the medical record does not really fully describe geriatric syndromes appropriately, and they have to go to the patient and the caregiver and the significant others. So what are the themes from some of these programs? Well, the strengths are that nurses play a primary role in transitional care. Most of the programs had an interdisciplinary team. They used predictive analytics to identify those that are eligible for services, and they really develop levels of intensity. These hospital-based models have the potential to be sustainable upon completion, and transitions to skilled nursing facilities are examined. Some of the weaknesses identified in this report are role confusion and role delineation as they're implementing these transitional care teams. Nurses, social workers, people don't really know what their roles are. They don't want to step on each other's toes. But I think that's what happens when people do interdisciplinary collaboration, and they really need to identify their boundaries. Nutrition is not fully integrated into the programs. Dietitians are missing from these interdisciplinary teams. One program with a dietitian didn't even have a dietitian at all sites, and nutritional decline was not defined. And although we think the the electronic health record is the holy grail, most of these sites reported issues with integrating EHRs or data across sites and across different settings, and issues with data use agreements. So, we have to form data bridges to get the data we need. So what are the gaps? So nutrition during care transitions is really was not a primary focus of the Healthcare Innovation Award programs. But are there other federal programs that focused on nutrition during care transitions, and what are some of the local programs that are out there? I found one study funded by the National Institute of Aging The study design is reported this year in American Heart Journal that looks at the DASH diet post-acute decompensated heart failure program. So what they're doing is randomizing patients to receive the DASH diet for 4 weeks post-discharge in 50 older adults with hypertension discharged with decompensated heart failure. And the primary site here is from Colombia. And this is really, I think, going to make a big difference in what we see, I think, in transitions of care, especially targeting certain disease states. Some of the other hospital-based post-discharge nutrition programs, which I found by searching Becker's Hospital Review and Google. So there's no registry of these different programs. These all consist of different kinds of meal programs where patients go home with meals. Academies Health in Indiana calls a Head Start nutrition program for seniors. So it's really, it all runs the gamut. And Steward Healthcare in Massachusetts implemented this City Fresh delivery program for heart failure patients. And they estimated that it would cost $66,000 a month for 55 patients. And this was in 2013. But again, you know, they would probably recoup that cost by preventing that readmission. And I just want to end here with this slide with, this is not just an issue here in the United States. In the UK, they're sending patients home with food-to-go bags, bags of milk, bread, orange juice, cereal, and food with a long shelf life to get people, kickstart them on their way to recovery. So then, what are some of the research priorities? Well, we really need to integrate nutrition risk assessment into predictive models to determine the levels of an intensity of a nutritional care that's needed post-discharge. And if we looked at some of these other models, you know, they broke them down into high risk, medium risk, and low risk. And the low risk was really delivered by a lay health worker, and maybe in the case of a nutrition intervention, maybe the social worker, because we have to get people connected to some of these community-based services. Medium intervention could pretty much be delivered by a nurse, but those that are really at high risk need the dietitian, and we need to get more dietitians in the community setting. Other research priorities that we need to focus on are maybe secondary, because now we have all of this data from CMS recipients, maybe we could do some secondary analysis of nutrition risk data from some of these big data sets to look at predictive models. So maybe that's something that could be done. We also need to focus some research priorities on best practices. We need to identify and review programs instituted or implemented by hospitals to address nutrition needs post-discharge. Just as I showed you in that slide, every hospital seems to be doing their own little thing based on what's available in their communities. And we need to identify the common elements of these programs, what it costs, what are the cost savings to the hospital, how sustainable are they, and most importantly, how this impacts patient outcomes. And I would be remiss if we didn't end this with some health policy priorities. Well, first of all, I think we need to expand reimbursement for registered dietitians. And right now, I think there is some reimbursement, right, in the community setting for diabetes, chronic kidney disease, I saw obesity. We need to also think about those with heart failure. Heart failure is a very big chronic disease in this country. Lots of transitional care programs are focused around heart failure. Why aren't these patients being seen by a dietitian? You know, I think this is something that it could easily get through. Because heart failure patients are at risk from malnutrition, and you know, they need important dietary modifications to modify their symptom management. I also think that we need to make a priority nutrition risk screening upon discharge, and we need to think about how we can incorporate this into transitional care programs. And while nutrition during care transitions may seem like an impossible task, I hope we work together to make it more possible. And thank you.